Hello everyone and welcome. Thank you for joining this session on point-of-care ultrasound of the cardiopulmonary system, primarily targeted to our third-year clerkship medical students. In this session, we hope to hit on a few case-based scenarios that help to demonstrate how incorporating point-of-care ultrasound into patients with cardiopulmonary complaints can make a dramatic difference into the care that you provide these patients. Not to be too dramatic, but I hope to demonstrate how you can use point-of-care ultrasound to tip the scales in favor of life over death in some of these patients with potentially life-threatening problems. We're going to approach this with 5 questions in mind, and those 5 questions are, as you see here, very simple, very straightforward. Is the heart beating? Is there a pericardial effusion? Is there left ventricular dysfunction? Is the right ventricle dilated? Is there some obvious valvular or aortic root pathology that you can clearly recognize? And the diagnostic framework, when you're encountered with these patients who have things like shortness of breath or chest pain, syncope, palpitations, things like that, those are the kind of the chief complaints that you might be thinking about. You're going to do your history and physical. You're probably going to order an EKG. You might order a portable chest X-ray. And maybe you're going to order blood gas. But what I want you to really think about incorporating point-of-care ultrasound with your history and physical. Think about it as an additional tool that adds to a well-done history and physical exam. And these are some of the indications we talked about. The most important ones would be they're in shock, they're hypotensive, maybe they're even in cardiac arrest. But then some of the other things we mentioned, chest pain, shortness of breath, syncope, palpitations, those are some of the most common things that we might be thinking about. And these could happen, they could come to a clinic, they could show up at an urgent care, you could get called to the floor for these kind of things. They obviously show up in the emergency department all the time. So these have a pretty wide-ranging application to a lot of specialties and scenarios. Just a few things to make sure. I want to be clear that we're not here to make you into a cardiologist in 20-25 minutes. So we're not going to be ruling out ischemia, ruling out a pulmonary embolism or vegetations. None of these things we're going to rule out. Some of them we may rule in, see findings that suggest them, but none of these things are going to be completely excluded just by bedside echo alone. And we're certainly not quantifying complex things like valve pathology. We're not going to cover diastolic dysfunction at all. Certainly not going to go over complex congenital abnormalities, and we're not estimating filling pressures. So always know your limitations. And so what we're going to start, and we're going to go through this again, case-based. So here's our first case. This is a 59-year-old male who's admitted for chest pain. So you're repeating cardiac enzymes. Maybe you're thinking about ordering a myocardial perfusion scan, something like that. Right now, maybe they don't have any symptoms. And here you see the vital signs look pretty unremarkable. But if you were paying attention, this patient has an example of obvious aortic root pathology. Let's go ahead and get into that. And that may lead you to the very critical diagnosis of aortic dissection. So the most easy and obvious thing here is this patient's aortic root is too wide. And if you remember your rule of thirds, the right ventricle, aortic root, and left atrium in the peristernal long axis view, we call it the rule of thirds. They should all be kind of equal thirds. Well, this third is too big. So this is a dilated aortic root. And then you can, if you see that and that clues you in, you can go and look at the rest of the aorta. And here you see in the abdominal aorta, we've got a mobile flap. So this is an aortic dissection. Here we see it as well in longitudinal view. A mobile flap within the aorta and a dilated aortic root in the peristernal long axis view of your echo. Sometimes you'll see a flap here as well. Sometimes the dilated aortic root is your only clue. And just to put a number on that, if you want to remember a rough number, the max should be 4 centimeters. You measure from outer to outer wall. And here, this one's almost 5. And just reminders of normal. So here we see that equal thirds. Left atrium, aortic root, right ventricle, all about the same size. Here's an example. This isn't the prettiest echo on earth, but you get a look here. You see this aortic root is way too big, and we can even see this little flap right here in this aortic root. So these are cases of aortic dissection. A critical diagnosis. If patients have symptoms, they have a mortality of about 10% per hour. So just pointing out that flap. And you can even see, I didn't point it out earlier, but if you're paying attention to the descending thoracic aorta, you can actually see the mobile flap in the descending thoracic aorta here in this example. A few more examples. Again, we've got normal as comparison. This one is even more obvious, very dilated aortic root and this highly mobile flap with an aortic root. This should be a very frightening image for you to look at. We also kind of secondarily see a pleural effusion here, kind of a side note. So in this case, even though they're asymptomatic, if you had them on heparin or Lovenox because they were admitted for chest pain, you probably want to stop that. And fortunately, this patient was able to undergo further imaging, delineating the extent of the dissection, and underwent a successful surgical repair. So moving into our next case is a 49-year-old female who's got chest pressure, some shortness of breath on exertion, however is asymptomatic at rest. Vital signs you see here look fairly unremarkable. Patient maybe has a mildly elevated troponin, and you're thinking, okay, we'll admit this person to evaluate for in-STEMI, something like that. Pay attention to those findings, and we'll kind of review those. So this patient has acute right ventricular dilation, and one of the primary reasons we care about this is in a patient with an acute massive or submassive pulmonary embolism, and echo can help us in these cases. So here we can see in this peristernal long axis view, the right ventricle is kind of overwhelming that equal thirds we talked about earlier, and it's causing compression on kind of squashing this left ventricle. So this is a dilated right ventricle. Here we see in this apical 4-chamber view again, just massively dilated. You don't need calipers or tools, you just need your eyeballs. You can see this right ventricle, massive, larger diameter than the left ventricle. You can see that compressive activity on the septum, which tells you there's pressure overload. A couple more examples. So here, this is similar to the last one. Again, here we see septal deviation towards the left ventricle and a dilated right ventricle. Now I will point out in this case we've got a pretty dilated right atrium as well, so that suggests maybe there's some chronicity to this, and that's something we have to keep in mind with all these diagnoses. There are acute and chronic findings, and we need to differentiate those partially by incorporating the information with history and physical and any other data that we have, and we'll talk about that a little bit more. This is what right ventricle dilation will look like on a peristernal short axis view. Sometimes we call this the D sign, where the septum is squashed flat to make the left ventricle look like a D. We see kind of massively dilated right ventricle. Again, here we see just eyeball diameter. Which one's bigger? The right ventricle's bigger. So these are some other signs. So this case, this patient who just had chest pressure, this doesn't have the typical historical context of pulmonary embolism, but everything doesn't present in the classical manner. Classical, if you look up the Latin for the word classic, it means 1/3 of the time. So we always need a broad differential for any patients that have these cardiopulmonary symptoms, and bedside echo as part of your history and physical should always be a component of that evaluation. So in this example, we see the right ventricle, the diameter is wider than the left ventricle. That's the easy thing to see. We see that septal deviation towards the left. That should mostly never happen in a normal patient. We see a little bit of what's called McConnell's sign, where we see the dilated right ventricle. We see kind of, this is not the most profound example ever, but there's a little hyperdynamic activity of the right ventricular apex. See how it's kind of contracting and pushing a little more than the rest of the right ventricle. So that's another finding that suggests right heart strain, and maybe a finding in a submassive or a massive pulmonary embolism. And before I move on, I should just point out that this only occurs in like 20 to 25% of pulmonary emboli. So you should not use this to rule out a pulmonary embolism, but it may direct you to the cause of a patient's symptoms. And in a patient who looks really sick, in respiratory distress, some signs of shock, if their PE is big enough and profound enough to be causing shock or significant respiratory distress, they're probably going to have these findings. So that's how you can use that. But in a patient who just has minor symptoms and maybe has a small subsegmental pulmonary embolism, you're not going to see these findings. So this does not rule out PE in an otherwise non-sick patient. So in this patient, who maybe this wasn't that high on the list, wasn't super suspected, this directed you to the right diagnosis, further imaging, and they were able to undergo a successful thrombectomy. So here's our next patient. This is a 38-year-old male who comes to clinic, who's had multiple visits in the last few months, keeps having symptoms of shortness of breath, sometimes some intermittent sharp chest pain. The vital signs look okay. This patient's otherwise healthy. Patient's been treated with albuterol and antibiotics and steroids, even been treated for reflux as a thought that might be cause of the symptoms. But you incorporate bedside ultrasound and see some of these findings to help you get the accurate and correct diagnosis in this patient. So this patient has left ventricular failure with multiple different findings, and we'll go over those. And this is one of the big questions. So do they have obvious left ventricular dysfunction? So if you know what a normal heart looks like, then hopefully you can easily recognize there's not much shape change in this left ventricle in the cardiac cycle, and the mitral valve is opening very poorly. So those are a couple of the big findings in poor left ventricular systolic function. So these cases both have very obvious left ventricular failure. Again, here we see kind of a thinner wall, and we just see overall decreased area or volume change during the cardiac cycle. So this is left ventricular failure. Same thing here, overall decreased area change. There's even regional wall motion abnormalities present here, where we see thickening in this septal area, but the rest of the ventricle doesn't thicken during systole. So this is another example or another variation of left ventricular systolic failure. And again, just pointing out, we're not using calipers or Doppler or anything else. We're just using our eyeballs, getting a decent image, knowing what normal looks like, and using our eyeballs to help us make these diagnoses. A few more examples from the subxiphoid and the apical 4-chamber view, where again, we just see a dilated left ventricle, very minimal area change or volume change during the cardiac cycle. Same thing here, very little area change during the cardiac cycle and a dilated left ventricle. These are obvious findings of left ventricular failure. Now there's multiple forms of left ventricular failure, of course. A hypertrophic cardiomyopathy is another consideration or another concern in patients who have symptoms of syncope or palpitations, or maybe they're having shortness of breath or chest pain. And just take a look at these kind of massively thickened, especially the septum, but there's even thickening of the lateral or the posterior wall. Here we've got thickening of the entire wall of the left ventricle. And again, no Doppler or color needed, just need your eyeballs and need to have a pretty reasonable understanding of what normal should look like. So these are other examples of left ventricular dysfunction, in these cases hypertrophic cardiomyopathy. And just incidental findings, I'll point out again here, we've got a kind of incidental pleural effusion, comes down to the side of the descending thoracic aorta. So in this patient who'd been kind of misdiagnosed for months, we can arrive at the proper diagnosis and recognize we've got a dilated left ventricle, not as much mitral opening as we expect, not as much area or volume change as we expect. So they've got a failing left ventricle, and we just reinforce those findings in our other views. Again, dilated left ventricle, not much volume or area change, not as much mitral opening as we expect. Similar thing here, not as much area change during the cardiac cycle. So this is a failing left ventricle. And then we get the additional findings where we look in the lungs and we see B lines in a kind of a symmetric pattern. And symmetric B lines should usually make you think about pulmonary edema. Here we see what you can sometimes see in heart failure is this is kind of the lower dependent lung field, and we see that looks like that's probably liver, and we see a small pleural effusion, which is often associated with patients who have pulmonary edema. Not always, but sometimes is present. So in this patient who had kind of been misdiagnosed and mismanaged for a few months, we can arrive at an accurate diagnosis, target the appropriate medical therapy, probably needs to undergo coronary imaging to see if this is ischemic or non-ischemic. In this case, it was non-ischemic. And then this patient may need other therapy, may need AICD, may be a candidate for LVAD, may need to go on heart transplant list, or in some of these cases, maybe they improve depending on what the underlying cause is and how they do with medical therapy. But they certainly aren't going to benefit from things like PPIs and being on albuterol. The next case is a patient who's a 19-year-old female who's had shortness of breath for a few days, just finished a Z-Pak for these symptoms. You see here the vital signs, and you incorporate cardiopulmonary ultrasound into their history and physical, and you arrive at kind of the accurate diagnosis that maybe the Z-Pak isn't going to help. So this patient has a pericardial effusion. So we'll just look at some examples. A pericardial effusion is going to usually have some circumferential component. So we'll see it anteriorly and posteriorly, although it can vary a little bit. So it wraps all the way around the heart. Now these are pretty large, pretty extensive effusions. We see a kind of swimming fat pad in this effusion. So these are pretty obvious. And I just want to point out, this could be mistaken sometimes, fat pad versus effusion. Here's the effusion where we've got fluid that's circumferential, and you see how much the shape of it changes throughout the cardiac cycle. It goes from almost gone to really thick, and you get the sense that the heart is swimming in there. In this case, this is a fat pad, and you can see it's kind of got some gray into it, and you can kind of see how it moves more with the heart, how because it's attached, and it thickens and thins a little tiny bit, but it mostly keeps its shape during the cardiac cycle, and we don't really see much of it or any of it posteriorly. These can be difficult, but look at some of these clues to help you differentiate fat pad versus effusion. One of the most common questions that comes up is that an effusion or is it a fat pad? And also want to point out that sometimes the fluid is not simple fluid. Sometimes in these cases where it's blood or clot, it can have components of gray. So here we've got some kind of grayish thrombosed blood components and some liquid components, so it's kind of mixed. In this example here, we see kind of mixed liquid, and some of this other gray stuff that's just kind of swimming around and floating is some of the partially clotted blood. So this is hemopericardium. And depending on the scenario, this should make you think about other diagnoses like free wall rupture, like aortic dissection. If this is in trauma, then it's a traumatic cardiac injury. But this may bring about a whole different set of differential diagnoses if you see these kind of findings. But you need to recognize that it's not all just going to be simple black fluid. And sometimes effusions can be focal. These are less common. In this case here, this whole thing is a large focal pericardial effusion, and you see it kind of compressing on the right ventricle. But depending on exactly how you slice this view or how you look at it, it could be missed. So here in this first peristernal long axis view, it's not really obvious. You don't really see it very well at all. We can kind of see it there, but the images were tough. Only in the subxiphoid view in this case do you see it very well. So this is just another reinforcement of why we should always get all of the views, because just different things are visible better in different views. And then if you see a pericardial effusion, then you also want to decide if this patient is tipping over the edge into cardiac tamponade. And what I want you to understand is that tamponade is not an all-in-one yes or no diagnosis. It lives on a spectrum, and patients can kind of tilt off of it or over it depending on their preload, their hydration status. Even if you go from kind of an upright to a supine position, you alter their preload a little bit, you can change them. And there are clinical findings as well as sonographic findings. So the decision on whether you need to drain it immediately or whether it can wait a little time to be drained is a decision that incorporates lots of data, including the echocardiogram findings, but also the clinical scenario. So one of the biggest findings, and this is one that I don't think is really reported that well or described that much in the literature, but is left ventricular collapse. If they're to the point where their left ventricle is small and shrunken, then they probably have at least some significant component of tamponade, because here you can see this left ventricle is almost squashed. You can barely see it. Here the whole heart's tiny. The left ventricle, if you measure that diameter, it's less than normal. So left ventricular collapse is kind of a closer to end stage finding, but almost definitely, I never want to say definitely, but is a high risk indicator of this probably needs to be drained sooner rather than later. And here's another example where if you didn't know what this was, all of this is pericardial effusion. These are the ventricles that are completely collapsed. So if this patient's not in cardiac arrest, they're soon to be. And this patient was actually, in fact, in cardiac arrest at the time of this image. Here are the atria. You can see they're still a little bit spared, but the ventricles are not even recognizable because there's so much fluid. Just reviewing some of the more advanced signs of tamponade, and these kind of happen over time. We see right atrial systolic collapse. So during cardiac systole, the right atrium will be collapsed. We should see a plethoric, dilated, or less phasic IVC. As it progresses a little bit longer, we should see diastolic collapse in the right ventricle. So you notice the valves are open here. That indicates cardiac diastole. And then a little more advanced one that I don't really think is typically that useful or applicable at the bedside is inflow variation of the velocity through the mitral valve. And that's probably a little more than we need for today's discussion, but that is something to look into further if you have interest. So in this case, this patient who had been feeling short of breath was treated with a Z-Pak for quote-unquote bronchitis. We find the real answer for why the patient is short of breath because they have a pericardial effusion. And in this case, they actually have some signs of tamponade. The right ventricle, you can't even really see it relax because it's completely compressed with fluid. We don't see super prominent atrial collapse in this patient, but we see circumferential fluid. We see no right ventricle. So this patient has at least some echocardiographic evidence of tamponade, and their vital signs, while not horrible, actually do hint towards pushing towards shock. But the patient was stable enough to undergo a semi-urgent, not emergent drainage in the cath lab, and their symptoms improved immediately. And in our next case, we talked about whether the heart is beating or not is a case of cardiac arrest, and during a pulse check you may want to do a quick point-of-care echocardiogram to look for is the heart beating or not, because sometimes we may have a weak pulse and the heart's beating, and there's a big difference between that and complete absence of cardiac activity. And in this case, we can see there's no cardiac activity whatsoever. Now, this may influence, depending on where you are in the resuscitation and these findings, this may help direct further decisions whether to continue or not. I should point out that the absence of cardiac activity does not by itself mean that further attempts are futile. However, if this is later in the stage of the resuscitation and you've done everything you can think of possible, this may give further confirmation, again, depending on the stage of the resuscitation, that efforts could cease. I'm not doing a whole thing on cardiac arrest here, but should point out that if you incorporate this early on to the resuscitation without interfering with cardiac compressions, you should be looking for treatable causes of cardiac arrest, which might include tamponade, may include signs of a massive PE, could include extending beyond the heart to things like attention pneumothorax, hemorrhage within the abdomen or the chest, other findings that may help direct your resuscitation and lead to treatable causes. Again, a little beyond our discussion today, but certainly bedside echo and other parts of ultrasound should always be incorporated into your cardiac arrest care. And then lastly, we didn't quite have a case, but just sometimes if you notice other obvious valvular pathology, you should make note of it, and sometimes these may help make some of your decisions. So in these cases, we've got some pretty obvious aortic valve calcification. So in a patient that has heavy calcification in the aortic valve, they've probably got some degree of stenosis as well. Now, we're not going to fully quantify their stenosis, but we may make note of this and recommend further evaluation of that. And maybe if they passed out, this could be a contributing factor, or if they're having anginal symptoms. So these are just things to take note of, just using your eyeballs. In these cases, this is one of the more common things you're going to see is mitral annular calcification. While itself is not that actionable, it's something you're going to see and you should recognize it. And typically if they have this, they're higher risk for other calcification and vascular disease. So take note of these calcifications, especially here at the mitral annulus. And here where we see the mitral valve kind of hooking during diastole and it doesn't open fully. So you see how it makes like this hockey stick appearance? That's almost pathognomonic for mitral stenosis. We don't see it as commonly here in the United States, but in other parts of the world this is very common. And again, you don't need special tools. You just need your eyeballs to recognize this. No calipers, no color, anything. You can also see kind of thickening and poor opening of the aortic valve here as well. That can be seen. But the most easily recognizable finding in rheumatic mitral stenosis is this kind of hockey sticking during the opening and incomplete opening of the mitral valve. And then if you get to the point where you are comfortable in using color, you should be able to identify obvious regurgitant flows. Again, this is probably a little advanced for what we're doing now, but something as you get good and gotten some more practice at doing your bedside echocardiography, something you can incorporate into your care. So we can see during systole, we get this obvious large regurgitant jet into the mitral valve. So these are both examples of mitral regurgitation. And blue is going away, and then the red goes back towards. So blue is coming out, red is trying to head back in. So the quick summary of the things we want to look at and think about in patients with cardiopulmonary symptoms with bedside echo. One, it should always be point of care ultrasound incorporated with your history and physical. So just make it part of your toolkit when you're doing your history and physical. You got your 5 questions, right? Beating, effusion, LV or RV failure, obvious valvular aortic root pathology, not quantifying this stuff extensively. And in your decision making, in cardiac arrest, you can look for some of these things and help make some of these decisions. I will point out that it's hard to tell if their RV's dilated or their left ventricle's failing if their heart's not beating. So if you just see cardiac standstill, it's hard to you can't really assess these that well. And then patients who are in shock or hypotensive, you quickly can rule out whether it's obstructive or not and change your differential diagnosis immediately. Look for signs of left ventricular failure or dilated aortic root. Again, things that are going to change the way you manage these patients immediately at the bedside without having to wait for other lab testing or other imaging. And then patients who have symptoms, maybe they look pretty good, they're fairly stable, so that they've got chest pain, they're short of breath, palpitations, syncope. Sometimes you find unexpected things that are going to change your management. So any of these things that maybe you didn't expect are going to change the course of care and change how you work up that patient further. And then we're not going to get into it in a lot of detail, but you may risk stratify these patients. Patients with syncope and chest pain and shortness of breath and palpitations, often you see them and they look good and their workup is pretty unremarkable. And doing bedside echocardiography gives you an additional risk stratification tool to help you decide, is this patient higher risk and maybe they need to stay in the hospital, they need more workup, or are they on the lower risk end of the curve to the point where maybe with all the other risk stratification you've done in evaluating them, maybe they're safe to go home. And this is something, I use this a lot in the emergency department to help send more patients home that are stable and are stratified into a lower risk category to kind of save some of those inpatient beds for the sicker patients. And then just the caution, we kind of touched on this a little bit, but a lot of these findings have acute and chronic etiologies. So for example, someone can be in shock and you look and you see their left ventricle looks horrible, but maybe that's chronic. Maybe they always have left ventricular failure. Maybe they've been walking around with it for years and now they're in septic shock also. So you always need to think about, is what I'm seeing the cause of their symptoms, or is it another factor that I have to deal with that's a component of their whole medical care? Patients in our population in West Virginia, we have a lot of patients with some component of chronic right heart failure due to all the COPD. So we may see a dilated right ventricle and it may not have anything to do with their acute symptoms. Maybe that's just a chronic finding, or maybe it's a component. It doesn't necessarily mean they have a pulmonary embolism. Maybe they have other causes of chronic right heart failure. Maybe that's pertinent to their immediate presentation and maybe it's not. So again, you need to use all the data you have with you. Bedside echo gives you a lot of powerful data, but it doesn't make all the decisions by itself. You have to be a clinician and use all the information you have to help you make patient management decisions. So with that, we're going to move from echo and talk briefly about point-of-care ultrasound of the lungs, because a lot of these patients, especially if they're short of breath or in shock or things like that, we may be pairing point-of-care lung ultrasound with cardiac point-of-care ultrasound, and incorporating the two can be incredibly powerful and give you a ton of great information. And there's 4 major findings that you look for in the lungs. It's pneumothorax, pleural effusion or collection, pulmonary edema, or other infectious inflammatory things, which I've kind of labeled here as pneumonia or pneumonitis. So our first case, you get your charge nurse grabs you have an elderly patient who quote unquote needs to be intubated because they looked horrible. You get there, they're obvious respiratory distress, they're kind of blue and they're hypoxic and tachycardic and just look awful. So you incorporate bedside ultrasound into their quick history and physical, and these are the findings that you have, and we'll go over these in a second. But this patient has a pneumothorax. So you got to ask yourself, is intubating going to help a pneumothorax or hurt it or indifferent? Hopefully you recognize that positive pressure with a pneumothorax is probably going to make them worse, and you'll probably kill them if they look that sick already and you put them on positive pressure. So the findings, hopefully this is review, but main thing is absent sliding. So here we see pleural sliding. Over in this example, we see there's the rib. There's a rib off here, but there's no pleural sliding. We see a pleural line that's just not moving whatsoever. So that's a pneumothorax. Now this by itself doesn't tell you how big it is or the extent of it, but it tells you yes or no, there's a pneumothorax. If you're using a curvilinear or lower frequency probe, it doesn't look quite as pretty, but if you're attentive and holding your hand nice and steady, you should recognize pleural sliding here, no pleural sliding here. So this is another example of pneumothorax. And then the next finding, which is not as common, not as easy to see, but is a lung point. This is the area of transition where you kind of see part of the lung sliding next to a part that isn't. So these are a couple of examples here with high frequency, where we see there's no sliding here ever during this whole cycle, but here we kind of see the lung kind of pop up and pop away. So this is a lung point. Over here we see this area where there's no sliding. We kind of see this lung come up and recede, come up and recede. This is a lung point, and a true lung point is like nearly 100% predictive of pneumothorax. So if you see a true lung point, then that's pneumothorax and it's not something else. Just be cautious. Some things can mimic lung point, like if maybe there's fluid right here and that interferes with the pleural line. That could kind of mimic a lung point. If you're up next to the heart can kind of look like a transition. Even in the abdomen, sometimes you can see the abdominal organs pushing up against your lung, and that can kind of mimic a lung point. With a little bit of experience, you can differentiate those, but if you haven't seen it that often, that could fool you, so just be cautious. So in this case, where the patient is looking really sick and quote unquote needs to be intubated, you quickly come in and recognize this side has no sliding whatsoever. So this patient with probably COPD popped a bleb, they've got a pneumo and they're in acute respiratory distress. Instead of intubating, you place a catheter, get a big whoosh of air, and this patient dramatically improves, and you don't have to intubate them, and you're thankful because you could have put this patient into cardiac arrest. So that's pneumothorax and what that looks like on lung ultrasound. Our next case, this is a 64-year-old male who comes in with acute shortness of breath. Patient has a history of COPD and CHF. They have diminished breath sounds. You hear crackles in their lungs. Blood pressure's a little soft. So, think about what you might be thinking about with this patient and how you might initially manage them, and then hopefully how incorporating bedside ultrasound might change how you manage this patient. So this patient has pneumonia, and that's why they're short of breath, and that's why you hear crackles. So let's talk about the ultrasound findings in pneumonia. They may just be focal B-lines in one area, or they might be in a couple of different areas, but they skip around and are very irregularly distributed. You may see thickening or irregularities along the pleura, and you may see even just real obvious large consolidations. So those are some of the things you might see. So B-lines again, but they're going to usually be irregularly distributed. They may be in only one focal area, so that's one thing. And then you'll usually see associated with that some thickening and irregularity of the pleura. You see here how the pleural line is not straight, it's not clean. It looks really ragged and like something's chewed on it. So this is an inflammatory or an infectious finding. And this is a little more deeper. You could call this a consolidation, although I'll show you even more severe examples. But the pleural line is irregular. It looks like it's been chewed up and it kind of dips down. So this is a small consolidation or a really significant pleural irregularity. So these are findings that are suggestive of an infectious, inflammatory, or pneumonia or pneumonitis type of process. If it's very severe, you'll see kind of the loss of any air. This is something that's sometimes called hepatization, where the lung looks like liver, and the air bronchograms are actually white, so we'll point those out. So those white lines are the air still in the bronchi, the only areas of air left in this lung. And then if you watch this thing move, you can kind of see the air moves, and here you see this is consolidation is close to the beating heart. So this is all looks like liver, but it's actually lung that has kind of no air left in it. So this case, where maybe you thought they're short of breath and you hear crackles and they have this history of CHF, maybe you think, oh, maybe they're in CHF and you want to start nitroglycerin and diuresing them. But you see their left ventricle actually doesn't look too bad. There's decent area change. And in certain areas of the lung here, there's no B lines. So that goes against pulmonary edema. And over here, we do see B lines, but we see these thick, irregular pleural regions chewed up and even like a consolidation kind of dipping down here. So this kind of can quickly lead you to the idea that, oh, they're short of breath because they have pneumonia and their blood pressure's soft because they're probably in early stages of septic shock. And again, if this is incorporated as part of your history and physical, you have this information right immediately to help you manage this critically ill patient before you go down the wrong diagnostic pathway. So the pneumonia was treated. You were actually able to give them some gentle IV fluids and certainly avoided nitroglycerin or any diuresis that would have made their septic shock worse. So our third case is a 54-year-old with acute shortness of breath. They're a smoker. They've got a history of heart disease. They look to be in respiratory distress. They have minimal lung sounds on the right, and they've got a poor response to nebulizer treatments. So this patient has multiple findings, the most significant of which here is a pleural effusion. And just again pointing out what pleural effusion is going to look like, you want to find the diaphragms on the kind of the side or posterior axillary line of the chest. So we've got diaphragm here we've got diaphragm, here we've got large pleural effusion, smaller pleural effusion, there's some lung, and we see kind of the spine hanging out in the back. Here we see descending thoracic aorta and the other thoracic structures. These are more complex pleural collections where they're just all irregular and there's kind of these web formations. There's really not a lot of liquid left. So this is actually what an empyema might look like. Chest x-ray and even CT is very poor at differentiating this from pleural effusion, and chest x-rays, especially mobile chest x-rays that we get all the time on the floors and in the emergency department, drastically underestimate the size and severity of these collections. So in this case, now I'll point out the patient also has B lines on both sides. So this is kind of a patient with pulmonary edema, but also a large right-sided pleural effusion. So we certainly are going to treat them for their heart failure with nitroglycerin, non-invasive positive pressure. We may need to diurese them as well. But if they've got a large unilateral effusion, it's reasonable to perform thoracentesis, which was done in this case, and the patient significantly improved, was able to come off of the positive pressure ventilation. So again, incorporating point-of-care ultrasound into your history and physical dramatically changes the trajectory and outcome for your patient. The next case, we've got 47-year-old female who's acutely short of breath, noted to have wheezing, and these findings in the lungs. Maybe you also look at the heart to give you some additional information in this patient who's short of breath, which again, someone who's short of breath, heart and lungs are kind of just part of your evaluation along with history and physical. So this patient has pulmonary edema where we see B lines that are pretty symmetrically distributed both sides of the chest. Often they're more prominent in the dependent areas, although that's not the case with every patient, but they should be, most of the time they're pretty symmetric. So here we see rib shadows, we see B lines kind of diffusely on both sides of the chest, maybe not as much up in these higher areas of the chest. So this is pulmonary edema. And again, sometimes patients with pulmonary edema, you will hear wheezing if you've heard of the term cardiac asthma. Pulmonary edema is really just the presence of B lines, which again, we talked about can be seen in pneumonia, but it's the pattern and how they're distributed in the chest. B lines just mean there's fluid in the lung interstitium. B lines start at the pleural line, they go all the way down, they're vertical bright white lines, and they move with the pleura. And just as a refresher, in pulmonary edema, they should be relatively symmetric, and you should see a relatively clean pleural line to tell you that it's not an infectious or inflammatory process. And that's what this patient has. But in pneumonia, B lines are going to be focal or distributed in a very irregular pattern, and you'll see pleural irregularities. Not as common, but you can see these in a pulmonary contusion, and you'll probably have a history of trauma to help you with that. And you can see them as a result of atelectasis as well. And again, that's going to be more in dependent areas, and usually it's going to be isolated to a focal region as well. So just a reminder that the B lines themselves are not specific, but finding B lines and seeing how they're distributed and the pattern that you see them within the chest is going to give you clues as to their etiology. So quick summary, the main findings we're looking for in lung ultrasound and pneumothorax, pleural effusion, pulmonary edema, or pneumonia, and kind of summarize the findings of what they're going to look like here. The way you want to approach this always is bring point-of-care ultrasound as a component or an additional evaluation as part of your history and physical. Get the information you need as soon as possible, and that's going to affect all the next step decisions that you make. And obviously you're often going to be checking other things like EKG, chest x-ray, maybe blood gases in these patients, but none of those things are going to give you answers and information as quickly as point-of-care ultrasound incorporated with your history and physical. So Incorporate it early, immediately in your patient with these kind of complaints. It's rapid, it's accurate, it's going to help you not miss important things, help you find things that you wouldn't have expected, and in some cases can have dramatic changes in care and outcomes for your patients. And I promise you, if you incorporate this into most or all of your patients with these complaints, you're going to find things that are going to save some of your patients' lives. And that's a pretty powerful thing that you can do with point-of-care ultrasound. So that was everything. I know it was a little bit longer, but a lot of content here. I hope it was helpful, and we'll see you in the next one.